everyone, and welcome. I'm George McAllister, analyst with MCL, and I'll be your moderator. We're glad you could join us. Our webinar today is New Jersey Case Study, the New Jersey Medicaid ACO Demonstration. Our speaker today is DeLia, research professor at Rutgers Center for State Health Policy. Before we get started, we just have a couple things to keep in mind. Our speaker will be taking your questions via the chat feature. While most questions will be addressed at the end of the presentation, you're more than welcome to send in your questions now and any time throughout the webinar. To chat, please click the blue talk bubble in the bottom left-hand corner of the screen. If you would like to receive a copy of today's presentation, you can download it from http://www.healthwebsummit.com/ACO060217.pdf. Lastly, if you require any other assistance, please contact the Healthcare Web Summit office at 209-577-4888. Derek, we're ready for you to begin.
Okay, thank you, George. Good afternoon, everyone, or good morning if you're further out west. So today I'm going to talk about the New Jersey Medicaid ACO demonstration. First, just a few acknowledgments of agencies and the Nicholson Foundation, private foundation in New Jersey, which has provided support for much of the work that I'm going to talk about today. So today I just want to give kind of a primer on what's going on with ACOs in New Jersey Medicaid. So first, before I get into really all the details of that, I think it's useful to keep in mind what were the really broad goals of this demonstration program. So it is a demonstration. It's designed to be an experiment that runs for 3 years. It's an experiment with accountable care and with shared savings mechanisms. And the idea is at the end of this 3-year experience, we want to take some lessons, learn from the experience, and use that to build out some broader reforms in the state Medicaid program. So this is designed to be kind of a slow on-ramp into risk-bearing and maybe a foundation for population-based payment later on down the road. So the shared savings mechanisms in the demonstration are set up to be all one-sided. So you get rewarded for generating savings, but there's no downside risk if costs go up for an ACO during the demonstration period. Another goal of the demonstration is to achieve balance between flexibility and oversight. Flexibility meaning the state didn't want to impose too many mandates telling ACOs what to do and how to do it. They wanted to see, who could set something up and be innovative, and maybe we can learn something from that. But of course, you do need to have some state oversight defining, what you're allowed to do during the course of the demonstration and quality assurance and things like that. And we're going to see a little later there's a real tension that's developed between these two issues, trying to balance flexibility and oversight. And then the final goal was that the state wanted to limit its financial exposure during the course of the demonstration. So the state was not interested in putting up a lot of new money for this. There was no federal money directed at supporting this demonstration per se. The state really was more interested in kind of nudging everyone in the Medicaid sector to try and do some innovative things, get the ball rolling, and then let's see what happens when people kind of set things up and put it in motion, on their own. So here's the timeline for the demonstration. Legislation was passed, signed into law way back in August of 2011. It took a few years for the final rules to be developed. It was a long process with draft rules and comment period, and it took them a while to get to the final rules in May of 2014. Then after that, there was a process of application where communities that wanted to form ACOs went through an application process that had to go through review, comment, and approval. And so by July 1st, 2015, there were 3 communities that received official certification to be designated as ACOs participating in the demonstration. So here are some of the key details of the demonstration. So it began July 1st, 2015. One of the areas of flexibility is that ACO communities could choose for themselves who they wanted their assigned population to be. So it's designed to be a geographic model. So ACOs take responsibility for all Medicaid enrollees who live within a particular geographic area. And it's up to the ACOs to decide what that area looks like. So the ACOs would decide on essentially a collection of zip codes, usually all the zip codes within a city or near the city. And the only real requirement is that there would have to be at least 5,000 Medicaid enrollees living within the targeted geography. And New Jersey is a really densely populated state, so meeting that threshold was not a problem for anybody who wanted to apply. So within the geographic area, the ACOs would be held accountable for total cost of care for all the Medicaid enrollees in that area. So this would include hospital care, physician care, prescription, mental health, long-term services and supports, and so on. Truly a total cost of care model. And all of that, particularly the shared savings arrangements, would be subject to reporting and ultimately showing some improvement in a variety of quality and outcome measures that were put forward by the state. And I can talk about them more later if people have questions. Another requirement to be certified as an ACO is you need to have a board of directors with multi-stakeholder participation. So it's more than just having healthcare providers. This demonstration was partly designed to try and address some of the social determinants of health. So part of the requirement is that on the stakeholder board, you need representation from social services and patient advocacy groups and community groups, which could be faith-based organizations or any other groups that are really active and participating in the community, so that it's a real population health kind of service model, looking broadly at some social determinants and not just medical care per se. There are shared savings embedded within the demonstration. So this is a requirement for the Medicaid fee-for-service population, and it's set up to be voluntary for managed care organizations. So this is part of the flexibility aspect, where the state did not want to mandate participation by the managed care plans, but instead wanted to set up a structure where there would be an accountable care organization that a managed care plan could contract with if they wanted to. And this is really important because New Jersey is a high managed care state in Medicaid. At this point, more than 90% of enrollees in Medicaid are in some kind of managed care plan. So managed care participation is really important to make this work well. So here's a brief look at the certification process. What does it take to be certified as an ACO to be in the demonstration? There are some provider requirements. So once the geographic area is defined, then the applicant community has to have all area hospitals participating in the ACO. They wanted hospitals to join the ACO and be more collaborative rather than competitive with each other. They want the ACO to be a mechanism where the hospitals all sort of row in one direction, trying to promote population health for the area. Also, you would need at least 4 behavioral health care providers agreeing to be part of the ACO, and at least 75% of the primary care providers who are participating in Medicaid within the area have to be part of the ACO. That's a requirement for certification. Also, certified ACOs have to develop gain sharing plans for shared savings. So within the fee-for-service part of it, this is an absolute requirement, but the ACOs can develop some of the details on their own as long as they're tied to the state-endorsed quality metrics. On the managed care side, there's some more flexibility. This is something that ACOs would negotiate with the health plans, and it would be subject to state approval and oversight, but they could work out terms on their own. So in the beginning, there were 7 communities that applied for certification, but only 3 received approval, and the 3 are located in Camden, Trenton, and in Newark. So the communities that did receive certification derive some benefits from that. So first of all, they're officially part of the demonstration, but more substantively, they can operate as an ACO where they're immune from any sort of antitrust action if they're collaborating or it looks like they're colluding on something. They're certified as an ACO, so they have state protection against any kind of antitrust issues that would otherwise arise. Certified ACOs have access to state funds, which actually kind of evolved later. So as I mentioned earlier, the state did not want to put up a lot of money for the demonstration initially. So initially, the communities that were trying to start ACOs, they relied very heavily on philanthropic funding. A lot of it came from the Nicholson Foundation, which is a group that I had mentioned at the beginning of my talk. Later, just as the demonstration was getting started, the ACOs were able to lobby successfully for some startup funds. So ultimately, each ACO that was certified received $1 million in startup money. Another benefit of certification is that the certified ACOs receive data feeds from the state. They get monthly data feeds that are based on all fee-for-service claims and managed care encounter data for all the people within their targeted geographic area. And this is important because the data covers utilization of healthcare providers that are not part of the ACO. The ACO is accountable for total cost of care, which means if patients are hospitalized or go to the ED or see a physician that's outside the ACO, they're still held accountable for that. So getting these data feeds allows them to see what their patients are doing outside that core group of ACO providers. One caveat to this is that for the managed care encounter data, the ACOs will not see the actual paid amounts to providers because that's proprietary. Those are private negotiations. So they can see utilization numbers, but not the dollars of spending associated with the managed care encounters. Certified ACOs also receive technical assistance from my center, which is the Rutgers Center for State Health Policy. So we maintain a statewide Medicaid claims and encounter database on our own with monthly updates, and we do have access to the proprietary data, the managed care payment rates, and so on. So with that information, we're able to do more detailed statistical tabulations for the ACOs. We don't reveal anything proprietary, but we can aggregate the information, and we can tell the ACOs, well, there are patients in your service area who go outside the area and they've used X dollars worth of hospital care, and then that's information that can be useful to them to think about what they want to target, how they want to manage services. Along those lines, we also did some work where we took our statewide database and developed some data dashboards for the 3 ACOs where they can take that information and they can look at different views in Tableau software, so they can kind of mix and match and cross-tabulate different things to try and answer their own questions about what are our patients doing in certain subgroups. Also, we're tabulating claims-based performance measures, which will be part of the demonstration, so that takes a little bit of burden off the ACOs. So along the way, a handful of challenges and controversies have emerged. So the first one was that there are 4 groups that applied for certification but did not receive it, which was clearly really disappointing to them. There are different reasons why applicants would not be certified. Some of them were not quite as ready to start on day one as other places. They didn't really have a tightly woven coalition of providers that was ready to go, at least not in the eyes of the state. But the really big issue was this 75% rule that I had mentioned earlier. So you need to have at least 75% of the Medicaid primary care providers as part of your ACO for certification. And the applicants all thought they had gotten there, but the state felt that a number of ACOs really didn't account for all Medicaid providers in the area. So that this was called the denominator problem. The applicants and the state were working from different denominators, and there was a little back and forth on this during the certification process. But ultimately, the state had decided for 4 of the applicants that they really didn't make the 75% cutoff, and that was a major factor in the 4 applicants that did not get certified. Another issue that arose along the way is how do you develop the performance metrics for the ACOs? In the beginning, people wanted to take a really wide, comprehensive look at care for the Medicaid population, but it quickly became apparent that with too many measures, it becomes a real reporting burden. And the providers in the ACOs are already reporting different measures for different programs for different payers. So after the demonstration got started, a lot of work went into some performance metric harmonization, so that if you're reporting something for one program, let's say DSRIP or something like that, try to make the ACO measures tie into that and measure consistently. So for example, several programs are interested in tracking mammography for women. But you want to make sure that the cutoff for mammography, if it's age 50 in one program and age 45 in another, that really adds to the burden. So some effort was made to make sure that the inclusion and exclusion criteria was consistent across different programs, so the burden would be reduced a little bit. Another issue that came up, which was actually a little surprising to me, is that originally the proposed measures were fairly detailed, a lot of them coming from either electronic health records or medical chart abstractions. And a number of the providers said, this is really burdensome to do all this, and why don't we just take information from claims data and make that the performance standard, which I found a little surprising because claims data don't include all the clinical detail that you'd want to measure clearly what's going on with patients. But because of the burden issue, the ACOs felt we'd rather have an approximate measure that's easy to calculate from claims rather than doing all the heavy lifting to do it with electronic health records or something like that. Another issue that has come up is the proprietary Medicaid managed care payment rates. So ACOs are accountable for all this spending. There's a lot of it they can't see, and so they have a hard time managing that. My group at Rutgers, we can provide information from time to time, really just giving a quick aggregate snapshot of some statistics. But the ACOs are really interested in having a more dynamic, day-to-day look at spending on a more regular basis. And right now there's no mechanism to give that to them, and that's been a real challenge for them. Also, there have been funding challenges. So the state put up some money initially for the ACOs, but it looks like they're not putting any more money into it for ongoing operations. Philanthropic dollars look like they are probably drying up as well. So the ACOs are left with some opportunity for shared savings, but we're early in the demonstration. It's not likely, I think, that you're going to see big savings right away, and even if you see savings later, probably not enough to sustain the operations of the ACOs. So that's an ongoing issue that ACOs are grappling with. Here's just a little chart that I won't go into in detail. This just kind of gives you an idea of all the organizations and the groups that are involved in the demonstration, and just how different groups depend upon one another to make some of the mechanisms of the demonstration move forward. But I know we're short on time, so I'll keep it moving here. So here's some major themes that we've learned recently about the demonstration. This is based on some detailed on-site interview work that I had done with my colleagues at Rutgers about the early operations and some of the strategies that are being pursued by the certified ACOs. So first of all, it's really worth noting that the 3 certified ACOs really started out in very different positions at the beginning of the demo. So one of the ACOs is a group in Camden, the Camden Coalition of Healthcare Providers, organized by Dr. Jeff Brenner, who lots of people might know. Over the years, Camden has gotten national recognition for a lot of innovative care management that they had been doing really before they became an ACO. And so they were ready to go from day one, and you know, they're making a lot more progress than the 2 other ACOs, just because, you know, they had been doing it for much longer. So I'll skim through these quickly and take questions later. So the first major theme from the first year of operations is that the ACO arrangements are part of really a larger population health improvement kind of activity in each community. So these ACOs exist, but these communities are doing other things outside the ACO which kind of overlap but are not necessarily part of the ACO. So the ACO is supporting some other work that's also going on. Theme number 2 is that the managed care organizations have been largely skeptical about the value of working with the ACOs, and that's a big problem because the managed care participation is voluntary. And so the ACOs have struggled a bit to get the managed care organizations to sign shared savings contracts with them. So Camden is the exception. They're farther along, and they've been doing this. But the other ACOs have struggled a bit with this, and have to really try to make the case that they have something of value to offer to the managed care plans. Also, the ACOs have really refined their care management strategies, since putting their applications forward in lots of different ways. Originally, a lot of the sort of the rhetoric around the ACOs in New Jersey Medicaid was to have a real super user, high user focus, look at the top 1% or so of spenders in the Medicaid distribution. And along the way, the ACOs have found that there's only so much you can do with that population, and some of them have high spending, but it's not necessarily changeable if it's pediatric cancer or severe trauma or something like that. So the ACOs are thinking through some other strategies, looking at maybe rising risk rather than high risk and things like that. Theme 4 is about how the ACOs are trying to create the right incentives and agreements with the ground level healthcare providers. And they're trying to do some creative things, trying to motivate the providers. I'll give you a quick example. In Camden, they have this idea called the 7-day pledge, where healthcare providers and people in the community essentially take a pledge where they say, if anyone in the community has been hospitalized, we're going to work together so that within 7 days of discharge, that individual is going to have a follow-up visit with a primary care provider. And there are a variety of incentives and community engagement tools that are set up to try and make that work, which I could talk about during Q&A if people are interested in. And then finally, the last theme is that the ACOs are really trying to continue moving forward, but the funding is very unstable and uncertain, so they're not exactly clear what they're going to do, how they're going to do it, but there is clearly a commitment to continuing the coalition strategy and to continue doing work beyond the demonstration, whether they remain an ACO or they call it something else is something that's kind of up in the air. But I think on the ground level, there's an ongoing commitment to continue doing something. Okay, so this is my last slide. I'll just skim over briefly some big takeaways. So in New Jersey, it really took a community, and it's taking a community to do the demonstration. If you think back to that complicated chart I showed you, lots of non-governmental organizations are involved in making some of these activities move forward. ACOs need quite a bit of data support to do what they want to do. It's access to data, it's help with data analytics, and working through some of the proprietary data issues that I had mentioned. Balancing flexibility with oversight has been a challenge in lots of ways that I touched on a little bit. And just wanting to be flexible itself is kind of risky. Nobody wanted to impose mandates on the managed care plans, but with voluntary participation, if they don't want to participate, it's hard for the ACOs to do a lot, and that's where some of them are right now, getting stuck in that. And there are the funding uncertainties, and what the ACOs will become in the near future is not exactly clear, but we expect they'll be around in some form. And I should just mention briefly that we're currently doing a quantitative evaluation with our statewide claims database, and we'll have some numbers to report probably sometime in the fall. So this slide just shows you a couple of reports which have more details about some of the information I discussed on the webinar, and my contact information is here. If you have questions or comments, definitely send me an email. So I think, George, I'll hand it over to you.
Okay, so our first question is, if controlling healthcare costs is 50% behavioral, the patient acting in a healthy manner, did ACO demonstration find it difficult to produce shared savings?
Yeah, so that's an area of considerable focus for the ACOs, and it's a real target area. That's one thing they all have in common. They're staying away from, I guess, what you call severe mental illness for now, but they're looking for people who have mental health comorbidities along with physical health problems, and they think that's a group that could be managed a lot better, and it's a real target area for them. That's where they think a lot of the savings are going to be, and we're just starting to look at the data now, so we're going to see if that plays out.
Okay, are the ACOs responsible for all Medicaid lives in their territories, or is it attribution more narrowly defined?
No, it's all the Medicaid lives in the area based on where their people live.
And one more question, how are pharmacy costs handled under the demonstration? Are prescription drugs part of the TCOC? Is there a single formulary for all three ACOs?
Yeah, so prescription drugs are part of the total cost of care. There's not a single formulary. Actually, the one thing to mention about that is in one of the arrangements with the managed care plans, there's been discussion about carving out some of the pharmacy, the Sovaldi kind of drug costs and things like that, because it appears to be skewing the data in ways that are not helpful. So that the pharmacy part is in there, but there's a rethinking about how they want to handle it.
And there's a question here. Did the Rutgers medical schools play a role, or have students or residents involved?
No, there was no direct connection with the Rutgers Medical School. This was really an initiative from New Jersey Medicaid, and they just went forward with it.
Okay, looks like our time is about up here too. We'd like to take this opportunity to thank our speaker and all the participants for joining us today. We'll be sending a follow-up post-event feedback via email before close of business today, and love to receive any feedback you wish to share. If you haven't already done so, please join our LinkedIn group on the web where you can post questions, start discussions, and suggest topics for future events. This now concludes our webinar.